So, so good morning, everyone. Welcome to our July Grand Rounds from the Osher Center. Um, my name is Gloria Ye. For those of you who don't know me, I'm the Director of Clinical Research here at the Osher Center. And it's a very special morning because we have this very special Grand Rounds this morning. So each year we have one Grand Rounds that really showcases the work of our current fellows or recent graduates of our T32 postdoctoral fellowship, formerly called the Harvard Medical School Research Fellowship in Integrative Medicine. So this fellowship has been continuously funded through the NIH for more than 25 years, and we're really just so proud to have been able to help, train the next generation of academicians in integrative health, and really very honored and privileged to have been able to work with such bright and talented and passionate young investigators. So that's who we have this morning speaking with us. So the three speakers are all recent graduates. Um, so what I'm going to do is I'm going to introduce each speaker prior to their mini presentation. At the end of all the presentations, we're going to do a panel Q&A with all of the three speakers, which I'll try to moderate. But please, I want the audience to just go ahead and put your questions into the Q&A box, not the chat, but the Q&A box function in Zoom. All right. And at any time, you can do that anytime, and we'll do our best to sort of get to them at the end. All right. If you are seeking CME credit for today's webinar, please send an email with the following pieces of information to HMS Osher Center at bwh.harvard.edu. All right, so I'm going to stop my share and introduce our first speaker. All right. So our first speaker is Dr. Jacklyn Foley. So Jackie graduated the T32 in 2023. She's currently a staff psychologist, clinical psychologist in the behavioral medicine program at MGH, Department of Psychiatry, and she's an assistant professor at Harvard Medical School. She's currently supported by a K-23 Career Development Award from the NHLBI, the National Heart, Lung, and Blood Institute, which she received in 2023. And she'll be presenting some of her work thus far on her K project this morning. Her clinical and research focus is on developing mindfulness-based multimodal interventions for medical populations with a particular interest in studying HIV, aging, and cardiovascular health outcomes. On the national stage, she serves as the co-director of the Behavioral Medicine and Integrated Primary Care Special Interest Group for the Association of Behavioral and Cognitive Therapies. Jackie, I'll pass it over to you.
Thank you so much, Gloria, and good morning. So not surprisingly, given Gloria's intro, the title of my talk today is The Development of a Multimodal Cardiovascular Disease Risk Reduction Intervention for Older People with HIV. So a bit of an agenda today. We are going to do a little bit of background. I do have quite a few slides, but I'm going to try to move quickly, but please ask questions. And we're going to talk about the current study, which is the K-23 Career Development Award. I'm going to share some, actually, I was realizing today, pre-published data that I have not published yet, as well as where we are in the science and what the next steps are going to be. And this is our wonderful study logo that you'll see on all the slides. All right, so for a bit of background, I like to always set this up for some non-HIV researchers, what the landscape is of HIV and what it's been over the years. And I actually really need to find an updated timeline because a lot has happened since the 90s. But really, what I want you to take away from this slide is that in 1997, we developed highly active antiretroviral therapies, and they were very effective, such that when we look at this graph, I like to pay attention to the green line, which is the number of people living with HIV. But the reason why it is steadily increasing is because also of this blue line, that with that invention of these new drugs right around that 1997 line, we saw the number of deaths from HIV drastically decrease. So, where we are now in this epidemic is HIV has long since moved away from being this fatal disease to now being something that is chronic and people are living with for many years. And because this is really the first time this has happened, we are, as they age, learning about what that aging process looks like. And for these individuals, what we're seeing is some accelerated aging in terms of what their body looks like, right? So someone with HIV, although they might be 65 years old, they don't exactly look like someone without HIV who is also 65 years old. And one of the ways we're seeing that is they are developing non-communicable comorbidities at younger ages, which does include cardiovascular disease, which is why I've had an interest in this for quite a few years. So people with HIV are disproportionately affected by cardiovascular disease, and you see this across a myriad of diagnoses. So we have significant increased risk, 44 to 79% for acute myocardial infarction or heart attack, 81 to 94% for heart failure, 40 to 156% for ischemic stroke, and 90% for just any coronary heart disease. So really significant disparities here. And then when we look at the proportions of death, if you look at kind of what people with HIV are dying from now, it's not HIV, and actually CVD or cardiovascular disease is a huge one. It's more doubled in recent decades. Why is this? Well, it's very complicated, and I could spend probably the whole 15 minutes going through this figure, but I will just very quickly say that we don't exactly know, but all of the science is pointing us in the direction of there are HIV specific biological factors, such that even though people are living with HIV, the virus is what we call suppressed in their body, meaning it's not replicating. A lot of times you can't even pick it up on a blood test. We would call that undetectable. It's still there, and it's still causing some changes to the immune system, right? It actually causes both an increase and a decrease of certain immune cells. And what this does to the body over time is it leads to chronic systemic inflammation, which has these downstream effects on cardiovascular health. It leads to endothelial dysfunction, atherosclerosis, and it also leads to metabolic changes. But that's not happening in a vacuum. There are also the more, you might say, traditional behavioral CVD risk factors, things like smoking, heavy drinking, physical inactivity, and poor diet quality that are often more commonly seen among people with HIV too. So those are also significant drivers. What further complicates this issue is that psychological distress also has a role in all of the processes I've already shown to show why people with HIV are at increased risk for cardiovascular disease. And people with HIV are more likely to experience distress, right? So distress is elevated among people with HIV, and it exacerbates particularly inflammation via biological and behavioral mechanisms. Do CVD risk reduction interventions now address psychological distress? Not really, I would say. You know, big scoping reviews of current CVD risk reduction interventions emphasize lifestyle modification or behavior change, of course, right? I'll recommend quitting smoking, a minimum of 150 minutes of moderate exercise or 75 minutes of vigorous exercise, a Mediterranean or DASH diet, which is intended to be, low in salt, high in quality, and also limited alcohol use. Although I will say there's some debate in literature, maybe Joe could talk about this, of what is a healthy amount of drinking, if any at all. Um, and I will say that if you look, most say, oh, hey, and you should address depression and you should teach stress management and address quality of life concerns, but there's no real recommendations on best practices and how we do this. And not surprisingly, then, currently, CVD risk reduction interventions that focus on behavior have only shown modest efficacy for people with HIV. I will say our group has done some work already with the diabetes prevention program, which I do think has the most promise for this group. It has been adapted to specifically address some of the things that are most critical to people with HIV, and it has been shown to show some improvements in markers of cardiovascular health when we look at blood pressure and cardiorespiratory fitness scores. And it's even been shown to have anti-inflammatory effects, but not for people with HIV, only general population samples. So we thought DPP seems like a great place to start, but I bet it would be significantly improved if we could include evidence-based strategies that target psychological distress to support the implementation of lifestyle recommendations and hopefully to drive down inflammation. So I thought to focus on mindfulness. Why? Because mindfulness-based interventions are efficacious at reducing psychological distress. We've shown this among people with HIV and people with CVD separately. And they're also efficacious at reducing these biological and behavioral mechanisms that link psychological distress to cardiovascular disease. So I think it stands to reason that mindfulness could be this integral intervention component to address CVD risk among people with HIV that addresses multiple and overlapping biological and behavioral mechanisms. Here's my conceptual model showing kind of the active ingredients or the mechanisms, if you will, of the proposed intervention that I'm going to talk about more in a second. But essentially, if we could take components of MBIs to teach mindfulness practices, could people get better at self-regulating, reduce psychological distress, which again, that part's already known. But what we need to see is how does that relate to CVD risk behaviors and immune activation and inflammation among this particular sample, while also, of course, giving them the tools they need to change their behaviors that we know are so critical to reducing cardiovascular disease risk. So in my K23 Mentored Career Development Award, the overall objective was to refine and synthesize evidence-based content from primarily MBSR, but as you'll see, I definitely went beyond MBSR or mindfulness-based stress reduction and the DPP program to develop and pilot test a new intervention that I call One Mind, One Heart. So these are the study aims. Aim one was to conduct semi-structured interviews with older people with HIV in psychological distress to solicit feedback on the proposed intervention content. Then the idea is to explore the initial acceptability of the intervention and study methods in an open pilot with exit interviews and pre-post assessments. And then finally, aim three will be to evaluate benchmarks of feasibility, acceptability, and potential for effects on inflammation and CVD risk behaviors in a pilot randomized control trial. And I'll share now that this is where we are and where we'll be talking more about today. So this was the original proposed intervention content from the grant itself. Again, I don't have time to go through everything on this slide, but I'll highlight some key points. It was intended to be 8 sessions. I had the idea to select what I hypothesized to be the most integral content of both DPP, propose some mindfulness content integration. We didn't do that for session one because everyone gets session one. And so session one is our like kind of enhanced usual care, if you will. So we didn't do any mindfulness integration at that point, since this is kind of the main part that we're testing. And then I also kind of showed how I first saw us adapting or adding new content because this is a new population with everyone being a person living with HIV. Session two was about causes of stress and links between stress and CVD and teaching both mindfulness-based strategies to cope with distress while also having a discussion about HIV-specific stressors. Sessions three and four were all about physical activity and thinking about mindfulness as a way to help people engage in physical activity, in part by helping address some of the key barriers for why people don't engage in physical activity in the first place. So thinking about pain or feeling uncomfortable or maybe like being judgmental of ourselves for not being able to do it, and so on and so forth. And then sessions 5 and 6 were intended to focus on diet, again, introducing some key mindfulness strategies to help promote diet, a lot on mindful eating, for example, but also, again, some on how self-critical thoughts might be a barrier. And then sessions 7 and 8 were intended to be about substance use sessions. So if people were smoking or engaging in alcohol use, or if they were not doing those things, thinking about additional strategies for coping with distress, because as you might see, there's a lot of overlap, right? Like to teach someone to non-judgmentally observe a craving, they can also non-judgmentally observe their distress and have it kind of show similar kind of mechanisms by which it decreases. So what did we do though? This was kind of what we proposed. And so we used semi-structured interview guides that really were a modeling of intervention content and skills. And then we asked people open-ended questions. Then we analyzed that data using a rapid analysis. Specifically, we did a framework matrix analysis, but still identified themes within that data. And that's what I'm going to show you today. So we interviewed 20 people. Here are the descriptors for our AIM-1 participants. Overall, they were about 62 years old. Our sample was about half Black or African American. We also had a pretty even split when it came to education. About half had achieved a high school diploma. The other half had gone beyond that. It was predominantly men. It was 80% men. Most were single, never married. Um, we were kind of again split between who identified as straight or heterosexual and those who identified as something else or as being a sexual minority. Income was also pretty variable across different income categories. And then overall, more about half of people had been living with HIV for over 30 years. So we're talking about people who had lived through even the earlier stages of the epidemic and beyond. Okay, so I've situated the qualitative data in terms of what we identified in DPP primarily that needed to be further adapted, and then what additional things people said they needed in order to be able to engage in these behavior changes. So I've linked this as qualitative theme we identified, and then how we chose to incorporate it in the intervention. So first off, suggested activities were not appropriate for older people with HIV. So in the original DPP manual and the suggested activities that people could engage in to be physically active, they were like, a lot of these don't apply for me. So we adapted them. You know, a lot of them are now like play with grandchildren, walk with pets, maybe even doing chair exercises if they have limited mobility. There was a lot of desire for community and peer support. So how we approached this was twofold. It was originally designed to be an individual intervention. So now we have individual, what we're calling like skills learning sessions. So that's staying the same, but we've now built in additional group support sessions where people who are learning those skills kind of along with you, but separate in their individual sessions, you all can come together in a group and talk about it and really help each other as you think about applying these skills. And we also further adapted the practices to encourage social connection, family engagement, and so on. And I apologize, I'm going to go through this a little quickly because by my time I have a minute or two left. Cost was identified as like the key barrier to healthy eating. So again, we adapted the intervention in two ways. First, we adapted meal suggestions to be lower cost, and we also added a resource guide that included meal programs, food pantries, and SNAP, and where you could kind of use SNAP, including at like local farmers markets. That wasn't enough, though. There was definitely people needed more. So, in terms of additions, a lot of it was what was coming out as the main barriers to engaging in these behaviors and how we might be able to address that that goes beyond the originally proposed content. So, for example, self-criticism was huge. And so we added a lot of evidence-based strategies to reduce self-criticism and improve self-worth through incorporating in some mindful self-compassion practices. Low or no motivation was also identified as a barrier. So one of the cool things we did per recommendations from participants was we added Garmin devices. So everyone's going to get a watch to help them count their steps. And people thought that that would be a huge motivator to change. And we also adjusted content to celebrate all progress and added language on how we might just need to refine goals if they're not being achieved. And that's okay too, to kind of just help people continue to build momentum. Health behavior change needed to be linked to person's values because guess what? Health is not the most valued across people. So we added some values clarification practices that sometimes linked it to family or other things for why they might want to be healthy if health itself wasn't all that motivating. Intense hunger was identified as a barrier to healthy eating. So again, we had mindful eating practices in there, but we kind of bolstered it. And we also added hunger fullness scales and set a goal to eat when at about 3 out of 10 hunger, with 0 out of 10 being like, I'm starving, and 10 out of 10 being like, I'm like excruciatingly full. So we're working with people on kind of finding that happy balance to help them make better choices. And so this is what the refined intervention content looks like. I am out of time, but I will highlight essentially what we did was we added all of the skills that I've mentioned previously. And I will say too, a lot of people said the substance use sessions did not feel relevant for them. So now sessions 7 and 8 actually go over the most common barriers to not meeting behavioral goals and teaching additional skills to help them overcome those. And that was probably one of the bigger changes. All right, I will stop there. I left no time for questions, but I can look at the chat.
Yeah, no worries. So, for those of you who joined a little bit late. We're going to go through each of the three presentations, and then we're going to do the questions all at the end with the panel. So, but at any time, feel free to put your questions into the Q&A. Thank you, Jackie. That was amazing. It's really exciting work. So we'll talk about it later. All right.
Thank
So
you. And
we're
if
gonna
anyone's interested, we're starting the open pilot like any day. I think we're screening people, so.
Yeah, so if you have referrals for Jackie, you can reach out. Um, all right, our next presenter is Dr. Heena-Manglani Terranova. I'm going to go ahead and share your screen, Heena, as I introduce you. So, Dr. Manglani Terranova received a doctorate in clinical psychology from The Ohio State University. She just graduated from our T32 postdoctoral fellowship this June. She's a licensed clinical psychologist and a researcher at Harvard Medical School and Massachusetts General Hospital. Her research focuses on improving whole health in people with multiple sclerosis and the use of mind-body interventions delivered during the critical period early after diagnosis, involving care partners and loved ones, spouses and family members, and examining psychological and social well-being. The overarching aim of her research is to empower people with MS and other chronic illness populations to live well over the long term by using mind-body strategies to cultivate agency, connection, and meaning, and using a whole person health approach to offer timely, scalable models for addressing the complex needs of these populations. Heena has received multiple recognitions of her work, including a grant from the International Neuropalliative Care Society to identify predictors of chronic emotional distress in patients and care partners in the first year after a MS diagnosis. Hand it to you, Heena.
Awesome. Okay, great. Thank you everyone for being here bright and early on this Tuesday. I'm really, really excited to present our ongoing results that we're working with from the study that Dr. Ye just mentioned. And so the title of my presentation is The Rug Got Pulled Out from Underneath Us: Psychosocial Experiences and Treatment Needs of People with Multiple Sclerosis and Their Partners in the First Year After Diagnosis. I have no conflicts to disclose, unfortunately. And so I am going to start off by presenting some background on MS. I'm going to be pretty brief because I really want to spend time on talking about our study design and dive into our both quantitative and qualitative results from this study, where I think where the meat really is. And then I'll summarize and provide a bit of information about future directions of this work. So, if you were to remember like 5 facts about MS, this is what you may want to know. First is that MS is a neurodegenerative condition that is twice more common in females than it is in males, and it's diagnosed on average at age 32, which is unlike other neurodegenerative conditions like Parkinson's disease and dementia, which tend to onset much later in the disease in someone's lifespan. And because of its onset so early, people are living with decades with all sorts of symptoms that impact physical function, psychological function, cognitive, and social functioning. It really impacts every bodily system that we have. And as you can imagine, where if people are experiencing a constellation of symptoms or even one of them, that can really have an impact on mood. And we do see that depression is 2 to 5 times more common, and anxiety is 3 times more common among people with MS compared to the general population. And with the impact that MS has on one's function, it doesn't just impact them. Care partners are also really vulnerable to depression and anxiety, with 44% reporting significant depression and 68% experiencing significant anxiety. And this distress between people with MS and partners is interdependent. And why is that? Think about what's happening in your early 30s. People are usually stepping into their careers, they're building their families, they're establishing their social networks, and suddenly they have to deal with all of these symptoms, still go to work, still take care of children, and still manage a lot of symptoms that are invisible. So oftentimes care partners play a huge role in supporting people with MS to just live and function as to the best of their ability. And so this experience, and what's great is Dr. Foley talked a lot about psychological distress. So you'll hear it a lot in my talk as well, is that the psychological distress that people with MS experience, as well as their partners, it can actually accelerate the disease and lead to greater disability and worse quality of life. But what's interesting is that not everyone experiences clinically significant levels of depression and anxiety. There are some people who are able to adjust to the illness and manage these mood changes and learn to cope. But for a large majority of people, that is very difficult. And so the question that we had with this project was, what if we could understand what needs people have in this early period after diagnosis? Maybe when they're the most vulnerable and when they're in the most need of services, so that we can then design interventions for them. And so that was the aim of this project. We wanted to understand psychosocial distress in both people with MS and their care partners in the first year after diagnosis, so that we can address those needs through psychosocial and mind-body interventions and really provide them more comprehensive wraparound care that can address risks at the patient level, at the dyad level, which means the patient and their partner, as well as the healthcare systems and the centers at which they receive care. So this study then we sought out to assess these two aims. The first being to quantify emotional distress in people with MS and care partners in the first year after MS diagnosis. And the second being to understand the impact of MS on people with MS and partners, their use of coping strategies, and their treatment preferences. So the way that we did this is, for the first aim, we administered a battery of questionnaires online to people with MS and their partners. And then we asked people, would you be interested in participating in a virtual focus group to tell us more about your experiences? And so then a subset of those participants also participated in part two of the study that allowed us to gather all of this rich qualitative data, which I'll focus on in this talk. So to participate in the study, we enrolled adults who were newly diagnosed with MS or had a partner who was newly diagnosed. And I should clarify, by partner, I mean loved ones, spouses, romantic partners, as well as family members or close friends. So we kept it pretty broad because we know that various different people in our lives provide different kinds of support. But I will say overall, it was more of romantic partners who ended up participating in the study. We required English fluency and literacy, and participants needed to have access to technology in order to participate in both the questionnaires as well as the focus groups that we did over Zoom. So our sample consisted of about 29 people with MS and 11 partners. And on average, you can see that this age of people with MS is, I don't know if you can see my mouse moving, but was just about the time that people tend to get diagnosed. We can see the predominance of women that aligns with the prevalence between women and men of MS. And you can see the breakdown of race as well, with 10 Black or African American participants and 17 white participants. And a few other, which also aligns with the distribution of MS across races in the US. Talking about distribution, we also had a majority of the participants identifying as having relapsing remitting multiple sclerosis, which is the most common type. And that's a type where people experience symptoms for these acute periods, and then they see some remission of symptoms, some improvement, not quite return to baseline every time, but there are these fluctuating periods. And so our sample also represented the different subtypes that exist and the prevalence of them in the community with MS. Okay, so I'm going to I'm going to present one of our quantitative findings in the next slide. And before I show it, I want you to know that I'm going to orient you to this graph. But the question I had was, what are the rates of anxiety and depression in people with MS and their partners? And how do they compare to the normative mean, the normative population or the general population? And then how do they compare between people with MS and their partners? And so what we found is in the red bars, we have people with MS. In the gray bars, we have partners. And this dashed line here represents the normative mean. The first two bars show scores on an anxiety measure. And the second two bars show scores on a depression measure. We use the PROMIS measures for this. And what we found is that across the board, people with MS and their partners reported significantly greater anxiety and depression than the healthy mean, meaning in the general population, someone of a similar age, same sex, would score about 50 on these measures, where you can see that scores are elevated for both people with MS and their partners. Now, what was surprising is that when we look at anxiety, when you compare partners to people with MS, partners actually reported slightly elevated, even more anxiety than people with MS. And this was statistically significant, which is interesting because one might imagine that the person going through the symptoms may experience greater anxiety, but actually this data suggests that anxiety and this uncertainty has a big impact on partners as well. I do want to note that caveat that our sample was limited. We only had about what was it? 11 partners. So this definitely needs to be replicated, but it does start to show some signs of the psychological distress experienced by partners who are often not studied in the literature. And it concords with what we heard in the qualitative interviews. So, a subset, 13 participants, 10 people with MS, and 3 partners participated in our focus groups to further describe their experiences and needs in the first year after diagnosis. So what I'm going to do is build this figure for you where I present the results from the qualitative focus groups that we did. And what we found is there's 3 big domains. We have biopsychosocial impact, their coping process, and their treatment preferences. So what I'm going to do is I'm going to lay out the different themes and sub-themes that emerged from our thematic analysis and present just one quote that I think exemplifies their lived experiences as well as preferences. So the person with MS gets diagnosed. The first big domain was biopsychosocial impact. And within this, participants talked about biological experiences. So, 2 themes that emerged were that fatigue interfered with responsibilities and the experience of invisible and individualized symptoms. One participant with MS said, it's very hard for people to relate. They don't know your level of tired. They don't know your level of pain. And so you may seem like the same person, but you don't always feel like the same person. So it talks about the invisibility of the symptoms as well as the often debilitating impact of fatigue that people experience. And then psychological experiences also emerged. People talked about a mental health roller coaster, fear of the unknown, and mixed impact of social media. One of the care partners said, I took the diagnosis harder than he did. He was very accepting of it. I call it our plot twist. It changed my whole world, my whole outlook on life. I fell into a depression for the first time in my life, like really depressed. I think I felt dread for the first time. I wasn't sleeping. I was waking up in the night crying. It rocked my world. And I will say that this was very similar to what people with MS said as well about this roller coaster that they went through when they were diagnosed. And with that, this uncertainty of not knowing what to expect and seeing all sorts of things on social media impacted their psychological function. Participants also talked about a social impact, including this burden of being misunderstood and reduced social engagement. One person with MS said, "It's just a lot of explaining. So that's how I feel. It's just hard to you're educating people so much." And this was consistent. We heard this a lot where people felt like they had to explain to people their MS because people sometimes had assumptions, and there was a lot of taking care of other people, even as a person who's actually living with MS. And oftentimes people were pulling back from social activities as well. And then in the last theme in this domain and the subthemes include changes to daily life and environmental modifications, limiting hobbies, living with restrictions, an overhaul of diet, and partners prioritizing the needs of people with MS over their own. So I'm just going to pull out one of the quotes that relates to diet. A care partner said, with food, that's been a really big adjustment for us. It's like the rug got pulled out from underneath us of what our lifestyle was. And we didn't eat bad, but we can't eat bad now, or he can't. So that means me too. So here you can see that these changes to daily life don't only impact people with MS. I don't have the quote up here, but another participant talked about how he moved to the first floor of their house and how that wasn't really helpful for his marriage because now he's living in different rooms from his wife. And so this these very pronounced changes to their daily lives impacting both people with MS and their partners. So, in addition to biopsychosocial impact, I'm realizing I'm 15 minutes in. Okay, so I'm going to go a little bit faster. The next domain was coping process. So people talked about coping from within, including taking one step at a time, slowing down the pace, staying mindful and grateful. And one of the quotes that stood out to me was, "I think it reminded me that I'm human. I was just doing way too much, burning the candle at both ends, putting a lot of stress on not only my body, but my mind and everything. It awakened me that I'm not a machine." So, in some ways, people really paused and they started to make changes that they knew were probably better for them. And then when in addition to coping from within, people also coped using external support. So they reported how education provided them with relief. They used mind body practices. They participated in psychotherapy and really got support from partners and other people, including support groups. So one participant talked about meditation, saying, starting meditation at home like Headspace. I noticed little things like I wasn't being as frustrated, just generally. That really made a huge difference. And I would like to continue doing that and making that a priority for just 5 minutes a day to make that kind of difference was truly shocking. A lot of people talked about yoga and returning or starting for the first time different mind body practices to help manage stress. And then the last domain has to do with treatment preferences. So participants talked a lot about their desire for education and skills. So what changes do you need to make in order to still be successful, to live, to thrive? Just different modifications you might need to make to your schedule. They wanted someone to walk them through. What do I do to live better and live healthy with MS? They talked about a desire for stress management, communication, and coping skills. I'm just going to highlight this one piece about it in this quote, which is from a care partner saying, most people taking care of MS partners don't get to have time for ourselves. So self-care techniques, coping skills, communication strategies, stress management, financial planning, that would be helpful. They were really wanting help in this way. They also talked about comprehensive and preventative care. This quote is a little bit long, but essentially, there is a nonprofit on Cape Cod for cancer where they provide alternative treatments. And this care partner said it would be so good if they could have this for MS. They could try massage, try to meet with a nutritionist or a dietitian, try acupuncture. They would be so thrilled to try different mind body practices if it was affordable and accessible to them. The other theme that emerged were, or the other, the theme that emerged were connections to community and specialists. People talked about wanting access to an MS navigator and really listening to anecdotal evidence, hearing what works for other people. Somebody just to check in, how are you doing? Symptoms getting better? And then what works for other people? What has really assisted other individuals and their breakdown of X symptom. Here are a list of things found most helpful from our users that would be really beneficial, something that's kind of tried and true. Participants recognized that science takes time, and they were just very desperate to hear things from the community that worked. Okay, and I'm wrapping up very soon. They also talked about wanting access to an MS professional, someone who's had a lot of experience with other people who they can ask personalized questions to. And they wanted these interventions to be tailored to their partners. What do friends, family, and partners need? What are the resources that they can look into for themselves? And they wanted flexibility, something that allowed them to get on when they could, when it was convenient for them. So you can see that there was so much rich information that emerged from these qualitative from these focus groups. And so just to summarize, the takeaways from this study so far is that we see that anxiety and depressive symptoms are elevated in both people with MS and partners relative to the general population, with partners reporting significantly greater anxiety than people with MS. We know that social support is a key factor in coping with MS and could be enhanced through connections to other people with MS, partners, as well as MS specialists. And finally, people with MS and partners report a desire for personalized, preventative, and comprehensive care, which includes a point person to help navigate the first year after MS. This is a pivotal time and they're looking for support. They're wanting it. They're very eager for it. So with that, I want to thank you for attending this session today. And I want to acknowledge my mentors, give a huge shout out to Dr. Ye, who's been a support through this project and my time through the fellowship, my research volunteers who have been instrumental, my funding, as well as, of course, the Harvard T32 Postdoctoral Fellowship for allowing me to do this work and supporting me. Okay, stop sharing.
Thank you so much, Heena.
Of course.
Really awesome work. And for both you and Jackie, your presentations, I really sort of see the whole person health and just how important, all these aspects, are. And hopefully we'll get a chance to talk a little bit more about it at the end. Gonna move on to our third presentation. Joe, if you want to go ahead and share your screen. So our third presenter is Dr. Joseph Rosansky. Joe is a clinical psychologist with expertise in the use of mindfulness-based psychotherapeutic approaches to behavior change. His research focuses on developing and testing mindfulness-based and integrative interventions for addictive behaviors, where he's received recognition and grants for his work, including the Harvard Medical School Livingston Award. Joe also just graduated from our T32 Research Fellowship in June and is currently continuing his investigations of integrative treatments for addictive behaviors at the Cambridge Health Alliance Center for Mindfulness and Compassion. His current project is focused on exploring the impacts of combining mindfulness training with transcutaneous vagal nerve stimulation on alcohol consumption. Joe's also the Associate Director of Psychology Training for the Center for Mindfulness and Compassion, and also works part-time at his private practice in Cambridge, where he specializes in mindfulness-based psychotherapy and helping people with sustainable, healthy behavior change. Joe?
Thank you. Thank you. It's really an honor to be here today. I will try to keep this succinct as possible so we have a little time for discussion at the end. So I'm going to be talking about the role of mindfulness training in the treatment of opioid use disorder. Just some quick disclosures. NIH funded the research that I will be discussing today, including NIDA and NCCIH, and my research was funded through the T32 Fellowship, which is funded by NCCIH. I have no other conflicts to disclose. So before I start talking about mindfulness training and its role in treating opioid use disorder, I just want to start off stepping back from that and talking about why are addictive behaviors so hard to change? Now, addictive behaviors, typically are seen as a problem, as problematic when they become harmful and a person cannot stop engaging in them. And there's usually two sort of two things going on behind this. The first is a conscious choice to use. And the motivational model of substance use suggests that every time someone uses, they weigh the benefits of using against the benefits of abstaining. And whichever one seems more beneficial in that moment, the person will do it. And this can at first sound a little bit confusing, except especially when people start to experience a lot of harms from their use. Except when we think about the variety of benefits that one can get from substance use. The most obvious maybe is increased positive affect or pleasure seeking. I think, it's kind of popular science, the huge sort of impact that substance use can have on the reward system and sort of dopamine levels. Um, Also can help by reducing negative affect. And this is something that we see a lot once someone progresses into dependence and we start to see tolerance and withdrawal symptoms. But even before that, it can be used to help cope with stress and other uncomfortable experiences. In addition, substance use is often a very social thing. And so someone may, for example, feel peer pressure to engage in substance use when their friends are doing it, to be part of the group. Um, Finally, although there are many more, pain management is another big reason that people turn to substance use, and particularly opioid use, which we're talking about today. In fact, many people who develop an opioid addiction have a underlying chronic pain condition that they turn to opioids to treat. But that's not the only thing that's going on when one makes the decision to use. After repeated use, people also develop what Weirs and Stacy's termed implicit cognitions. And these are sort of the habitual, unconscious, reflexive responses to drug-related cues, to triggers that will lead someone to use. These include things like attentional biases. So, for example, when somebody with a substance use disorder is in a room with substance-related cues, their attention is going to be drawn to it, right? Someone who has an alcohol use disorder, who is standing talking to someone in a bar, may spend more time looking at the alcohol than somebody without one. But in addition, there's also this sort of group of these unconscious reflexive responses that are called approach action tendencies. And they result in this sort of unconscious movement towards using. So much so that sometimes people with substance use disorders will establish substance use disorders, will report using substances without thinking about it at all, right? In this very sort of habitual way, as if it's on automatic pilot. And without thinking, they can engage in the use. So in action, when a person who's developed these implicit cognitions is in the presence of a trigger, and that trigger could be a person, a place, a situation, a smell, really anything. These approach action tendencies are engaged, right? And they will start moving towards using in this very sort of automatic way. Now, if nothing else happens, this will generally result in substance use. However, and particularly once someone has entered recovery or is working on recovery, oftentimes, hopefully, there will be barriers, right, to stop these approach action tendencies. Now, these barriers could come from the outside. It could be a family member saying no. They also can come from the inside, right? And we can think about sort of, prefrontal cortex, right? And sort of this more sort of slow, logical, rational processes, someone telling themselves, I don't want to use. And if they can catch that approach action tendency in time and stop it, then they will have the experience of craving. So craving is often associated with uncomfortable emotions that will result when these approach action tendencies, these urges, these unconscious urges to use are unable to be fulfilled. And craving can include really strong emotions like anxiety, sadness, sometimes even panic or pain. And one of the ways that individuals can relieve these uncomfortable emotions and these urges and this craving experience is to use. And that's why I think in many ways cravings are such a focus of substance use treatment, because they can often, even when someone doesn't want to use and has many reasons, the barriers, the emotional, physical, psychological experience of the craving can be so uncomfortable that they still use anyways. So why mindfulness? Well, mindfulness can help people work directly with both the conscious and the implicit cognitions, right? So both the sort of motivational decision benefits of using versus abstaining, thinking about those, and really tapping into those implicit cognitions. And mindfulness, I think, is particularly useful for these unconscious implicit cognitions because it helps people learn how to sort of step back and observe all of these different experiences that are going on inside of them, the thoughts, the feelings, the urges, the emotions. Um, in addition, mindfulness has been integrated with many other established interventions for substance use for addictive behaviors, including cognitive behavioral therapy, motivational interviewing, and others. Evidence also suggests, and there's a substantial body of evidence now that shows that mindfulness training can be a really helpful treatment for things like chronic pain, anxiety, and depression. And these are some of the most common comorbidities that individuals with substance use disorders, more specifically with opioid use disorder, experience. What about medication-assisted treatment? Well, this is really has developed into the gold standard right now for treating opioid use disorder. And I think most commonly it's done with a combination of buprenorphine and naloxone. Naloxone is added to reduce the abuse potential. And we've really, I think the RCTs have shown tremendous improvements in substance use, in craving, and in mortality, both from overdose and all-cause mortality. I mean, it seems to be safe and effective. Uh, Unfortunately, only about 50% of patients who start buprenorphine treatment will remain engaged with it after 6 months or 24 weeks. Some of the predictors of retention are psychosocial stress as well as comorbidities. So those same comorbidities that we were just talking about mindfulness helping with, pain, anxiety, depression, are also things that can be associated with treatment dropout when individuals are engaged in buprenorphine treatment. So my mentor, Dr. Zubstream and Olivier, had this idea of why not combine mindfulness training for individuals who are receiving buprenorphine treatment, because it can help with these comorbidities. And we developed a mindful OBOT study. This was a project I worked on, a large RCT. Took about 3 years for us to finish. It happened right in the middle of the pandemic. And we targeted individuals between the age of 18 and 70 who had been on a stable dose of buprenorphine for at least 30 days. And we also targeted individuals who were experiencing either symptoms of anxiety or had continuing substance use, despite being stabilized on buprenorphine. This was not opioid use typically. In fact, I don't think opioid use was not very prevalent at baseline, but there was some reports of cocaine use and benzodiazepine use and other substance use. And what we did was we randomly assigned participants in a 1-to-1 ratio to either receive 24 weeks of mindfulness training or 24 weeks of inactive control. That was essentially the gold standard treatments for substance use disorders: CBT, motivational interviewing, 12-step reinforcement. So it's fully remote. We had a pretty geographically diverse sample, as you can see, the plurality coming from Florida, followed by Texas and Massachusetts. A predominantly white sample, and that does reflect national statistics on buprenorphine treatment, which does not seem to be equitably provided across racial backgrounds. So we looked, our primary outcome was opioid abstinence. All substance use outcomes were biochemically confirmed using oral toxicology screening that was video monitored on Zoom. We also looked at changes in anxiety and pain interference, as well as opioid craving. Interestingly, there were no differences in our primary or secondary outcomes between groups, meaning that both treatments performed about the same. There was very low rates of opioid abstinence, as well as very low rates of cocaine, sorry, very low rates of opioid use, as well as low rates of cocaine and benzodiazepine use, and improvements in both anxiety and pain interference across groups. However, the mindfulness group did show a differential reduction in opioid craving. And you can see that on this plot here. The darker line is the MROC group, which is the mindful recovery sorry, the mindful recovery from opioid use care continuum. And when we break that down by week, we can really see that this reliable change emerges after about 12 weeks. And so as a secondary analysis, I wanted to look at, you know, is the first 12 weeks different from the second 12 weeks? And we were also really interested in finding some mediators, right, of what sort of might have contributed to this change. So I ran a linear mixed effects model, and what we found was that indeed the primary change happens during the first 12 weeks, and there was no significant effect for week. So you can see week 0 to 12 is bolded. So in the first 12 weeks, there was a change happening. In the second 12 weeks, 13 to 24, non-significant. So no significant change. And there was interaction term, which indicates that the mindfulness group had a greater rate of change over those first 12 weeks. Not surprising when we looked at the graph, compared to the control group. Interestingly, none of the Maya subscales were associated with this change, despite recent findings, to the contrary from other studies. And I ran a bunch of other sort of models looking for mechanisms that may explain this change. We did not find any relationship between changes in FFMQ or any of the subscales or the decentering subscale of the experiences questionnaire of any of the real mechanisms we looked at. So this suggests that group-based psychosocial treatments can contribute to an additional reduction in opioid craving after patients have been stabilized on buprenorphine. And really that 12 weeks is probably the optimal amount of time. Mindfulness training appears to provide greater reductions in residual opioid craving than non-mindfulness approaches, while providing the same benefits to substance use, anxiety, pain interference. So I know we have like 2 minutes for questions. Apologies for this. So I'm continuing to analyze the data, but I have not found any clear mediation that would explain this differential impact. My hypothesis is that it may facilitate this through habituation to the experience of opioid craving. Don't have much time to talk about it, but I'll leave you with this beautiful picture of what urge surfing looks like, which is a technique that I think may facilitate habituation. Apologies. Thank you for your time and attention.
All right. Thank you so much, Joe. Yeah, no worries. I think I'm going to just allow us to go over for a few minutes just so we can, have a couple questions and then wrap up and not feel like we're just being rushed off. So I think wonderful. Jackie and Heena, looks like you guys were able to answer some of the questions that came through the Q&A function already. But so I'll just pose one that came in for you, Joe, that you probably haven't had a chance to take a look at yet. So it's a question about motivational interviewing approach for addictions. Somebody asked about the approach was developed at the University of New Mexico for substance abuse for those who do not respond to AA. And it's also been used at Mayo. We have a paucity of community, social, state, and national support to address such a complex issue. So any thoughts regarding motivational interviewing or other techniques that might be helpful for addictions?
Yeah, I believe very strongly in motivational interviewing. In fact, so as my mentor Zev also really supports it, so much so that as soon as I started years ago, working with him, the first thing he asked me to do was to train the research coordinators in motivational interviewing, and we have continued that process. I think I would encourage anyone who's interested in working with patients, even if you're not a therapist, to look into it. I know a lot of physicians who have found it really useful in their work as well.
All right, wonderful. Oh, so sorry, Jackie had to sign off, but Hina, are you okay for a couple minutes, both of you guys? Okay,
Yeah,
wonderful.
absolutely.
So I just wanted to ask a question, I guess, to both of you. I just had so many thoughts when I was listening to the presentations, and one of the things that came up was like, all of these underlying symptoms that in all of the populations, whether it's, HIV and stigma, whether it's MS, these invisible symptoms you're talking about, and, Joe, for folks with addictions that, we don't necessarily see maybe like the underlying pain disorder or that social acceptance, like it um, just really feel like there's so much that is underneath that we don't see. And I guess just a broad question is, do you have thoughts about how we can better I don't know, recognize that or acknowledge that, in the populations that you guys are working with? It's not one that
Do
we
you want
talked about before. Sorry, spring this on you, but yeah,
Oh,
any
no, it's
thoughts about
okay.
that? And yeah,
I think it's
either of you.
interesting, Gloria, because it's something that other people may not recognize, but even the person living with it or experiencing those symptoms may not always fully have it at their awareness too, because some of those symptoms are so complex and we tend to avoid, at least when I think about psychological distress, like it's, like let me just not think about it, or let me just busy myself doing all the things that make me feel active and I'm taking care of things. So in terms of if your question is like, how do we help folks who may be experiencing these invisible symptoms be able to better address it? I think as healthcare professionals and researchers, I think it's our ability to sort of put it on the table and saying a lot of people, given where you are, experience fatigue and cognitive issues and withdrawing, and is that been your experience? So I think it's a bit about normalizing it, validating it, and maybe planting the seed so that they can further converse about that with their, care partners and as well as with their healthcare professionals.
Yeah,
I don't know what you
yeah,
think, Joe.
and us also not realizing that it doesn't just affect the individual, but those around them, in deep ways.
Hmm.
So, Joe, any thoughts at all?
Uh, Yeah, I mean, I think it's very true with something like opioid use disorder as well. I have often been struck when, working sort of one-on-one with a patient, and when I'll say something like, a lot of times people have shared things like X with me, and they say, "Oh my God, yes, how did you know?" And I think not everyone fits into the same, sort of box. And so I think it is also so important, to kind of have a respect for those individual differences and to kind of take a personalized approach to this, especially because, with something like addiction, harm reduction works for a lot of people. I mean, there was a paper, it was probably 5 years old now, but it was looking at sort of long-term outcomes, and it showed that, individuals who these were drinkers, continued heavy drinking, but in a non-problematic way, that they were able to maintain it for 5 years, some subset, right, at the same rates as people were able to maintain abstinence. And so, recovery doesn't look the same for everyone when it comes to substance use disorders. And I think that's an important thing to keep in mind as well.
Awesome. Okay. I'm going to add like 1 minute for each of you. So the two last questions, and then we'll try to wrap up. But I wanted to ask you, Joe, so mindfulness for other addictive sort of or other yeah, addictive behaviors. Can you say a little bit about that, or also for folks who are not necessarily on buprenorphine?
Yeah, absolutely. So not only is mindfulness useful for people receiving buprenorphine, it has been shown to be really effective for people with opioid use disorder not receiving buprenorphine, although there's a lot less research specifically looking at opioid use disorder. So I'd like to encourage people to, if you're interested in this, to look into that. Um, However, mindfulness-based relapse prevention, mindfulness-oriented recovery enhancement for people with opioid use disorder have all been really well established. And we see the most interesting thing, I think, is that we see the same evidence of reductions in craving. Again, we don't usually compare to such a strong active control as we did in our study. But a study of mindfulness-based relapse prevention found that while similar reductions in cravings were observed between the CBT and the mindfulness group, the mindfulness group's reductions persisted after treatment ended, while they did not persist in the CBT group. And so that to me is a really promising indicator.
Okay, awesome. Thank you. One for you, Hina, is just to ask about the care partners versus the MS patients. Do you feel like everybody needs to get the same intervention? Are there sort of treatment specific sort of targets, for both
Mhm.
care partners as well as those with the patient, with the diagnosis?
I'll give you an answer that one of the participants said, which is when I asked that question, they said it'd be really great if we started together in a group format and we all sort of got the same kind of education and skills, but then we split off. So then there's a group for partners and then there's a group for people with MS that was tailored specifically to what was most important to them. And I think that really maybe would be one ideal way of going about it because there are some unique needs that people experience as a person living with the condition and as partners, but it allows for some common shared understanding of mindfulness skills and other coping skills that both partners can learn and practice together and support one another in using through their course of adjusting to the disease.
Yeah, yeah. Thank you guys so much.
Of course.
You can see we could have done, an hour for each of you. Maybe next time we won't try to get three all in the hour. But thank you all for the research that you do and for shedding light, on all of these really important areas to affect our patients' health. So thank you again. So I'm just going to do a couple of very brief sort of outro announcements. I'm going to just share my screen here again. Here we go. Okay. Can you guys see my screen?
Yes.
Okay, great. Yep. So just the announcement of our grand rounds for next month, August 5th, is Sophia Mata, extending health span, advancing mind-body interventions for warrior well-being. So she's going to be talking about some of the work that she's done with acupuncture and trauma and brain health with those in the military. So please join us. Same time, eight to 9 o'clock. And then I just wanted to say a quick word about a conference that myself and Peter Wayne and the Osher Center are sponsoring. This will be our second um, uh, international conference on the science of Tai Chi and Qigong as whole person health. You can take a look at our website. That's on the slide. It's going to be next April in 2026 here in Boston. Call for submissions opens actually today, so you can still see that on our website, both for symposia, panel discussions, and scientific abstracts. So I hope you all check it out and consider attending. And then last but not least is our sort of ask for any donations if you feel so inclined to help support the work that we do here at the Osher Center, either a general donation or if you want to support any of these specific initiatives, please do reach out. And again, thank you all for being with us this morning. Thank you to Hina and to Joe and to Jackie for all that you've done. And you are our shining light, and we're proud, mentors and faculty of the T32 to being able to work with you guys. So thank you all, and enjoy the rest of your day.